Alrighty, so it looks like we're recording, so we are good to go. Thank you everybody for coming and welcome to Physician Pathways. Today we have with us Dr. Keniesha Thompson, and she is a hospitalist here at SLU, as well as an assistant dean of student affairs. And so if you've been to one of our interviews or see one of our interviews before, this one will be just a little bit different because she does serve in both of those roles. So we'll be able to ask her some questions about her work as a hospitalist, as well as some specific questions about career discernment, because I know a lot of us are thinking about that. And so just to start off the interview, and I'm Erin, by the way, and my co-interviewer, Aman, will be leading today's session. And so Dr. Thompson, just to start off, can we have a little bit of background about a little bit more about you and what led you to where you are today?
Yes, thanks, Erin. Thank you guys for having me. So like Erin said, I'm Keniesha Thompson. I am an internal medicine physician here at St. Louis University. And in addition to that, I am assistant dean of student affairs. So I have been at SLU for the past 10 years, and I actually came to St. Louis University as a trainee. I was a trainee in internal medicine. I did my internship and residency here at SLU. Background about me, I am originally from Jamaica, so I am an immigrant. I came to the United States in the early 2000s, and I was able to attend high school, undergrad, and college here. So my undergraduate was at Howard University in Washington, D.C., and I did my medical school at the University of Kansas in Kansas City, so not too far from here, about 4 hours across the state. Like I said, I ended up coming to St. Louis University as a resident. I matched into internal medicine at St. Louis University, and that's kind of what brought me here. My path to my current role, I did my residency training at SLU, really enjoyed being a generalist in internal medicine. I decided to do a chief resident year. I was fortunate enough to be selected to be a chief resident in internal medicine. And then I was asked to join faculty, and I've been here ever since.
Awesome. So touching on your career training in internal medicine, what made you choose that subspecialty, and specifically, why did you want to become a hospitalist?
So great question, Aman. So when I was in medical school, I really had a turning point when I decided to do internal medicine. I really loved everything about my third year of medical school. I had a lot of great experiences in all my rotations. And as I was moving along throughout my time, I tried to reflect on what the ideals I viewed as my career, what kind of ideals I looked for. And during my time on my internal medicine clerkship, I really liked how detailed my attendings were when it came to taking care of patients and the care and attention that they would spend with their patients. It was really reflective of how I saw myself as a future physician. So that was very helpful. In addition to that, I really liked the patient population. I like taking care of adult patients. I like the rapport that I was able to develop with my patients on that service. And I just saw that I could fit in well with that crowd, essentially. The patients are, sometimes very complex. And sometimes it takes a lot of detail orientation to really understand what's going on with a patient. Sometimes you have to dedicate a lot of time to figuring out when you have mysterious cases of patients. But I think that also keeps us on our feet because it makes us learn as we're continuing to take care of patients. So those were some of the things that I really liked about internal medicine. In addition to that, I would say I like being on the inpatient side because I got to spend a lot of time with my patients. So versus being on the outpatient side where you have short appointment times, or being in the emergency room where you have a rapid turnover of patients, I found that I really like to be able to spend my time to take care of the patients, to really talk to them and to get to know them very well. And the hospital setting really provided that for me personally.
So going off of that, I know you mentioned previously that you were selected to be chief resident. So keeping in mind some of our undergrads in attendance, Can you describe like what some of your responsibilities were?
Yeah, so great question. So the chief resident role, so residency is 3 years in internal medicine. Your first year is kind of considered your intern year. That's when you're doing, I would say, the most learning. As a senior internal medicine resident, so your second year and third year, you're more or less put into a supervisory role. You're still learning, but you're now in charge of medical students and residents on your team as well when you're on the inpatient side. And then as chief resident, our role and responsibilities were sort of in threefold. The first dimension was being in an administrative role, taking care of the daily demands and the daily needs of your residents. The second dimension was in teaching. So a lot of your responsibilities were focused on the curriculum for the residency training program, ensuring that all of the trainees were learning the necessary information that they needed to learn as residents. And then the third dimension was actually serving as a attending physician on the inpatient service, mostly on the inpatient service. So after your 3 years of residency in internal medicine, essentially you are qualified to be a fully trained internist at that point. If you are fortunate to be selected as chief resident, a lot of people see this as a next step in their career. For me, it was important for me to be a part of that process because I wanted to do medical education. And like I mentioned before, teaching is a huge responsibility for the chief residents. So I felt like I really got a chance to spend that year honing my teaching skills and really getting more into the medical education field, understanding what the expectations are as a teacher in medicine.
Awesome. Thank you for explaining that a little bit more. I know I was curious about it too. So can you explain a little bit more about what med students or some of the undergrad students we have should know about internal medicine in general, maybe like what your on-call schedule is like, what a day in the life is like, or even touching on where people can go after an internal medicine residency?
Yeah, that's so one of the reasons I liked internal medicine as a potential career was actually the opportunities that were still available to me, even at the end of my training, if I decided to pursue them. So a lot of times when you hear a lot of specialists speaking, for instance, you hear from cardiologists who are the doctors that specialize in the cardiac system, so the heart. You might hear from pulmonologists in the media. You know, during COVID, they were very heavily in discussion about how COVID was affecting the lungs and the body. Pulmonologists and critical care doctors do that. All these subspecialties are subspecialties of internal medicine. So all these physicians actually receive their first 3 years of training in internal medicine. They're fully licensed internal medicine physicians at the end of those 3 years, but you can decide to subspecialize to any of those subspecialties. So cardiology, pulmonology, gastroenterology, critical care, nephrology, those are the doctors who focus on the kidneys and disorders that are associated with the kidneys. Hematology, oncology, the doctors that are focused on disorders of cancer and other blood dyscrasias. Palliative care physicians, geriatric medicine doctors. These are all subspecialties of internal medicine. And when you encounter one of these physicians, they are almost 100%, they will have completed their training in internal medicine and then subsequently gone on to do additional training. Some of the fellowship programs are 1 year for palliative care, ranging from 1 year to 3 years, 4 years, 5 years. Some of the super specialized cardiologists, for instance, they will do the 3 years of internal medicine training, another 3 years of cardiology training, and maybe 2 years, for instance, our electrophysiology doctors. They are focused on really just looking at this arrhythmias of the heart. That's when the heart is beating out of range. And I just consider them to be the smartest people. They do a lot of physics to figure out what they're doing and to fix those kinds of things in patients. We really need them. But it takes a lot of time and a lot of dedication to have that specialized knowledge, but they're all internists at the end of the day. So it's really great to be a part of a team that I get to refer to them as consultants, oftentimes when I'm in the hospital taking care of patients. Did I answer your question, Erin?
Yes, you did.
Okay.
And switching gears a little bit, what do you like the most about your job as a hospitalist, and maybe what do you least like about your job as a hospitalist?
So what I like the most about my job as a hospitalist, I think I kind of mentioned or hinted towards a little bit earlier, was the amount of time that I get to spend with my patients. The other thing that I like about being a hospitalist, patients come to the hospital when they're really sick, and they usually are in a state that, you really don't want to be in. You really don't want your family members to be in that state. So it really requires a lot of compassion when you're taking care of those patients that are in the hospital. But a lot of times they're coming to the hospital with conditions that I can actually intervene on, and I can make better, and I can get them home. And that is the part that gives me the most joy, when I can see somebody in a really sick state, but I can provide them with treatments, medications, procedures that can really help improve their overall health and get them on the right path to healing. So those are some of the things that I really like the most. I'm a problem solver. I really like problems, and that sounds kind of strange to say, but if you think about it, a lot of internists are really into like puzzles. We're really into things that require a lot of mental stimulation. So, having a patient that comes in with a complex medical issue that we really have to do some digging with regards to maybe looking at literature to try to figure out what's the best route to treat them, what's the best medication, what's the best pathway to getting them better. Oftentimes, I think of us as being very inquisitive, but also efficient in the way that we approach our inquisition. So it's really important that you can intervene rapidly to take care of patients so that they don't get worse, but also come up with the best treatment plan for them. So those are some of the things that I really like about hospital medicine and internal medicine as a whole. In terms of things that maybe you could say are not the best parts of hospital medicine, a lot of times there are things that are affecting your patients that have led to them being in the hospital that you don't have control over. And I feel like that's the hard part, right? So I get my patient better. Maybe they came in, for instance, they have a history of diabetes and their blood sugars were totally out of control when they came to the hospital. While they're in the hospital, I can fix that. I can give them insulin, I can give them medications, I can give them fluids, I can make it better while they're in the hospital. But then when they leave the hospital, a lot of times I don't have control over what goes on with regards to them being able to access their medications. I might be able to provide them with a certain amount of bridge to get them to feeling better for a few weeks, but in the end, whatever is the underlying reason why they weren't able to attain their medication, sometimes I don't have the resources to be able to intervene on that. So that's one of the issues that I find, or one of the biggest challenges that I have as an internist in the hospital. As far as our schedules, I think we have a pretty decent schedule. A lot of times you'll hear about the hospitalist schedule being 7 on, 7 off. And what 7 on, 7 off means is usually we're working in 7-day blocks of time. So we'll work for 1 week at a time in the hospital, and then the following week we're not in the hospital at all. So that's where we get the 7 on, 7 off schedule. Some of our shifts will be anywhere from 8 hours to 12 hours. So sometimes those 7 days are long days that we're taking care of patients. But it's necessary to provide that continuity and to be able to really come up with solutions for our patients' problems. It's really helpful for that. So 7 on, 7 off. 7 off. Some people really take advantage of that from a personal lifestyle standpoint. I have some colleagues who will oftentimes travel on those 7 days off because you really don't have any responsibilities to patients once you're out of the hospital. So when you're here, you're really dedicated to your patients, but when you're not here, that can be your time. My path is a little different because, like you guys know, I'm Assistant Dean of Student Affairs. So when I'm not in the hospital, I'm here in the medical school working with you all. But for some of my colleagues, they really do take advantage. They travel a lot. They're always out of town, enjoying their life on those weeks off.
And then, so touching on both of your roles as a physician and as an assistant dean, how would you say you balance those roles? I know we just talked about 7 on, 7 off, so that seems to make a little more sense to me. But could you talk a little bit more about the time that you devote to each, and just what that looks like for you, and where you're able to find time really for yourself outside of your roles in your work?
Yeah. So for me, I get a lot of strength, and I take a lot of fun out of being able to work with students directly. So for me, being off on my off weeks and being here in the medical school, it doesn't feel as much like work, honestly. When I'm in the hospital, I really do have to dedicate my time to just being in the hospital. So a lot of my meetings, I may, either postpone, or I will defer a lot of meetings for the weeks when I'm not in the hospital, because being in the hospital and taking care of sick patients, that is really a full-time job, obviously. It means that, I'm connected to a phone. I'm either in a patient's room or working on charting, documenting my discussions with patients, documenting my treatment plans for patients. So those days are really full. Sometimes I'm talking to families, I'm discussing with consultants. If I have a teaching team that I'm working with, a lot of times I'm working with residents and medical students. And on days when I have a teaching team and I'm in the hospital, some of my time will be spent actually providing small lectures to the students and the residents as well. So those days are really full. On the days when I'm not on service and I'm here in the medical school, some of those days I'm in meetings, a lot of meetings. I serve on a lot of different committees with relation to either student support, academic support committees. I'm also a part of the Diversity, Equity, and Inclusion Office. So sometimes I'll be in meetings with that team as well. And then a lot of it is around building strategies to support our students and figuring out the best course of action for our learners. So in terms of balance, I have a family, so I spend time when I'm not here in medical school or in the hospital. I spend my time with my family. I try to limit checking of emails, and I try to limit my work in terms of doing presentations and things like that. I try to limit that to the times when I'm here in office, and so that I can spend my time with my 2-year-old and my husband outside. I'll give you an example. This past weekend, I was not on service, I was not on call, and I was not here in the med school. I was out biking in Forest Park. So if you guys are biking in Forest Park, you might run into me from time to time.
And talking more about your role as an assistant dean of student affairs, what led you down that path? I know you talked about earlier how you really like teaching. So was this more of like a sudden thing, or just gradually over time you decided that'd be a really good fit for you?
Oh, that's a great question. So the more I got involved with the medical school and medical education, I really found myself providing a lot more mentorship to our learners. So I was a learning community mentor. I was a mentor to my learners in the residency program as well. I was also associate program director for the internal medicine residency program. So that was one of my chief roles as associate program director in the residency program and as learning community faculty as well. So thinking about mentorship, putting that in one box. And then my other role recently was being clerkship director. So I served as one of the co-directors for the internal medicine clerkship. That's the clerkship that all of our third year medical students go through. In that role, I had to learn a lot about evaluation and feedback, a lot about curriculum development, and a lot about how our learners learn. So how adult learners learn and how to make our material be interesting enough for you all, but also fulfill the content that it needed to fulfill, to provide the content that we needed to provide. I think it's been a culmination of all of those roles that I've had that's led me to this role today. I don't think there's one necessary path to this role. Putting it all together, I think, is what built the skills that I needed to be able to do this job and to do it well. So in my current role, my primary responsibilities are in career advising and development of the career advising and specialty advising program. So those are kind of the tasks that I'm being championed with right now. And you guys probably remember that this is fairly new for me. So I've been in this role since January as assistant dean. Previously, I was both associate program director for the internal medicine residency program and clerkship director for the third year med students.
And then going off of that, do you have any advice for medical students who want to become, part of medical education, or if you have any like leadership qualities that a good physician should exhibit?
Yeah, so as we're talking, I'm kind of reflecting on some of the other activities that I've done either during medical school or even prior to medical school. I did a lot of tutoring, and I think that has a lot to do with how I interact right now with learners. So thinking about their needs more so than coming into it with an agenda is important. So tutoring, as you know, it really requires you to figure out what the learner knows, what they need to know, and where they need to go, even if they don't know. So sometimes it requires you to give them the skills to be able to figure out where they need to go. And then sometimes it requires you to provide them with information. So I think being a tutor has really helped me with that. I was a tutor in undergrad. I tutored chemistry, biology in undergrad. During medical school, I was a tutor to my colleagues. In the M2 year, I was tutor to M1s. So I've had this teaching kind of role throughout. Sometimes it was in a larger context and sometimes it was in a smaller context. But I've always been a teacher since I was in undergrad. I've always been some sort of teacher. And I think seeing yourself as a teacher is really important. Even now, if I don't have learners, I'm still teaching my patients. On the days when I don't have learners and I'm taking care of patients, there's always opportunities for me to provide information to my patients that can make their health better. As physicians, it's really important that we keep that in mind as well, that we're teachers for our patients. So being a teacher, I think, is one of the ultimate jobs that we can possibly have. And as physicians, it doesn't exclude us from being a teacher.
Awesome. And then just shifting gears a little bit more, given your experience working a lot with students, is there any specific advice or are there any resources that you would suggest for students kind of struggling with their career discernment? Any ways that people could get out there and explore their career interests a little bit more?
So there's two ways to go about this. And I think if you do one, doesn't mean you can't do the other one. So as medical students, you guys have access to the Careers in Medicine resource. It's a AAMC website. We've essentially given everybody that comes into the School of Medicine with access to Careers in Medicine. The Careers in Medicine is a great resource for students, and it really breaks down different aspects. It really provides information at different aspects of your medical education career. So starting at the beginning of the year, the careers in medicine really is focused on you learning about yourself, understanding yourself, and you guys should have gone through one of our recent workshops where that was kind of the goal. So I'm bringing these workshops to you guys through the learning community and through different activities as well. So understanding yourself, the second phase of the careers in medicine is to really explore options as far as career options, getting to learn more about career options. Again, this is all within the Careers in Medicine platform. And then the third and fourth stages, I would really relegate to your third or fourth year, which is really choosing a specialty and preparing for residency. So reviewing the resources that are around those areas. So Careers in Medicine is a huge resource. They have personality quizzes on there that you can take to figure out what kind of personalities would, or what kind of specialties would most likely fit with certain personalities, depending on the personality quiz, how you respond to those. So I think it's really cool to explore that. And then the other thing is shadowing. I think shadowing is huge, taking advantage of shadowing opportunities that come your way and reaching out for shadowing opportunities as well. As medical students, you guys have direct contacts to a lot of physicians. So really taking advantage of shadowing, spending an afternoon with somebody, maybe 2 afternoons with someone could really tell you a lot about how they practice and what that practice might look like. And then, I said 2 things, but the third thing that I want to keep in mind is to be open-minded. I really did not select what residency or what career I wanted to do until my 3rd year of medical school. So be open-minded, and but as you're going through either your preclinicals or clinical training, you will start to figure out what things about different specialties you like. And I think you should really listen to your heart at the end of the day, but be open-minded and exploratory.
Thank you. That was a great answer. As we wrap up this session, I wanted to ask you, if you're looking back, is there anything you would wish you'd known or done differently when you were a medical student?
That's a great question. Anything I wish I had known or done differently? I think I would have possibly done more in terms of shadowing. I was just talking about shadowing in terms of shadowing earlier on in my medical school career. I think I would have ultimately made the same decision. But having exposure to as much of medicine is important, especially if you're coming into medicine and you don't have, for instance, a family background that supports you having exposure to medicine previously. I think a lot of my colleagues, a lot of medical students in general have, either a parent or relative that has been through the process. So really seeking out mentors early, it's really important, and getting exposure to different fields. We're people, physicians are people. So, these conversations are great. I'm glad that you guys are having these conversations and doing these interviews, because I think that really breaks down the barrier. Because a lot of times students, they want to ask questions, they want to ask the deep questions, but they feel, oh, but I can't ask Dr. Thompson that. But, it's really important to talk to them about what their life is like, what their family life is like, what they enjoy doing outside of being a physician, because a lot of times you make connections that way, and you can kind of see yourself in different areas by understanding people. So getting as much mentorship as possible, finding a mentor. You all have been provided with mentors in the learning community. So communicating with them, keeping in touch with them is really important. And then finding yourself other mentors, depending on your interests, I think is also important.
Thank you. That's all the questions that Aaron and I had. So if anybody in the audience has questions for Dr. Thompson, feel free to type in the chat or just unmute and ask.
Here, I'll ask a question if you guys can hear me.
Hey, Luke, I can hear you.
Hi, yeah, thanks for coming, Dr. Thompson. Sorry for the several emails. But
No, thank
so
you.
something I've always wondered when I'm like shadowing and stuff is if I'm getting like a 4 hour experience or 8, if I do 2 or 16 even, or even like a 2 week clerkship, am I only getting like the wow factor of that specialty? Like if I go shadow, trauma surgery, as someone who's never seen that before, that's going to be super cool. But I have no way of knowing if I'm going to like that for 20 years. Like how do pre-med students and medical students kind of navigate, you know, uh, avoiding that wow factor of stuff, if that makes sense?
Yeah, that's I kind of get that. Yeah, that's a difficult one. But at the same time, so there's the wow factor, but I think if you're wowed by it and you get exposure to more things, then you know what you're not wowed by. And I think that's really what's going to help you be able to discern. I'll give my own personal example. So I really had no exposure to physical medicine and rehabilitation. And I know a lot of you guys don't have exposure to that either. But it was something that really piqued my interest during my 3rd year. I saw a little bit of it working with patients that were going to rehab and trying to figure out what that other side looked like. So physical medicine rehabilitation really was on my radar as something that I could potentially do. And what I did was I planned a sub-I in PMR and I planned a sub-I in internal medicine, and they were back to back. And so I did my sub-I in internal medicine, absolutely loved it, just had a great time hanging out with my attendings and my residents and really being that primary person working with the patients. And then I went to physical medicine and rehabilitation, and a half of my rotation there was spent on the inpatient side and a half of the inpatient rehab hospital. And the other half of my rotation was spent in the clinic working with PMR doctors in the clinic. And I really gravitated towards the inpatient side. And it just kind of solidified my reasoning for why I liked internal medicine. So a lot of the things that were different about PMR was the things that they were doing in clinic. So they were doing injections in clinic, and they were doing examinations and nerve conduction studies and all these amazing things, but they weren't things that really were sparking joy in me. And being on the inpatient side and really hanging out with the patients on the inpatient side was what was really calling to me. So it really solidified that internal medicine really was the path for me. So exposure to different things, I think, is important. Really being able to compare and contrast different patient populations, figuring out, oh, do I like pediatrics? Oh, do I like women's health? Do I like, where can I get the most out of my experience? Because if there's something that you like on trauma, there may be similar exposures that you could get on orthopedic surgery, and maybe there's something about trauma that you're not getting, but you're getting on orthopedic surgery. So it really, or maybe it's like, okay, I like that aspect, but I don't want to do the surgery. Then sports med might be for you. So there are so many like small things that could help you differentiate different specialties. But if you don't have exposure to it, then you won't really know.
Yeah, that's good to hear. Thank you.
Thanks for your question, Luke. Ooh, somebody's making me time travel now. If Jack, if you could go back in time and tell your undergrad self something to be better prepared for medical school or residency, what advice would you give? That's a good one. So I actually have a different answer than what you probably expect to hear. I viewed each step of my career in singularity somewhat, knowing that I was building onto the next step, but at the same time, not thinking too far ahead. So I think it's really important that you're focusing on where you're at in your training and not getting overwhelmed with what the next steps are. So for instance, when I was in undergrad, I was really focused on being the best that I was at that stage. So being the best biology major, being the best student that I was at that stage, knowing that in the future, I'm going to have to take the MCAT, I'm going to have to go to medical school, I have 4 years of medical training to do, but really focusing on what I was learning at that point really helped me prepare for what was next in the path. If you get the foundation down really well, then it's less of a hurdle when it comes to taking the MCAT. You already know the physics, you already know the chemistry, you already know the biology. It's less of a hurdle to learn that material when it comes to the next step, which is taking the MCAT and applying to medical school. So really being focused on the level of training that you're at, I think is important. And taking the time to really get experiences that will help you with that career discernment in the future is also important. So volunteering in a hospital, being a part of a, shadowing someone in clinic, taking the time to do those things. If you have a semester when your workload is not as heavy and you really have the opportunity to volunteer, feed the homeless, do different things where you're getting to know people that you might not have exposure to just being in college, I think is really important as well.
I have a quick question for you, Dr. Thompson. I think that at least for me, I don't really know much about, what it's like to be a chief resident. So I was just wondering if you could just quickly go over what the process is like if you're a resident to try to become a chief resident, how advanced, how early do you need to know that that's something you want to do? And what are the benefits of it other than maybe going into medical education in the future?
Great question. So it really depends on the specialty that you're going into, and also the program that you're in. So for instance, a lot of internal medicine programs around the country, their third-year residents are chiefs, or in our case, our fourth year was a chief year because we completed our residency training after 3 years. So to get into being the chief resident, that position, that decision was made during the second half of my second year. So I was more than halfway through residency at that point when that decision was made. It is around the same time when people are making the decision about whether or not they want to subspecialize and apply to fellowship positions. So speaking on that, one of the added benefits of being a chief resident is the leadership opportunities that you get. And being in a leadership role in general is viewed very positively when it comes to future careers. So either that future career is in medical education, or if you want to be in administration when you complete your training, or if you want to go into a subspecialty, they really do value leadership skills in those areas. So being a chief resident is an instant stamp that you have those leadership skills and qualities. So a lot of my colleagues, for instance, that are now cardiologists, gastroenterologists, when they were applying to fellowship, immediately they received more fellowship application interview offers than our colleagues that had not done a chief resident year. So I had fellowship, my colleagues applying to fellowship that were getting 12, 15 interviews, whereas our third year residents at the time were getting 5 or 6 interviews. But it's that leadership skills that they know you possess as having been a chief resident that really sets you apart from your colleagues.
And so is it always where do you have to take an extra year in residency to be the chief, or is that happening concurrent with your last year of residency?
So for some residency programs, it's concurrent, and it depends on the specialty too. For instance, the general surgery chief residents, they're all the 5th year chief residents or serve as chief residents in general surgery. So it depends on the program, it depends on the specialty. It really varies.
Thank you very much.
No problem.
It doesn't look like we have any more questions. So I wanted to thank you, Dr. Thompson, for this great interview, and all the attendees for joining us this afternoon. and hopefully we see you all at the next Physician Pathways interview.
Thank you guys so much for the invitation to be here today. And if you have any follow-up questions or you want to meet with me to talk about careers and goals, feel free to reach out to me and we can get an appointment on the books.
Thank you.
Thank you.
Thank you so
Thank
much,
you,
Dr.
Dr. Thompson.
Thompson.